So let's continue. All right. All right. Oh, one other thing. If you have questions when you're doing your tests and the answers are not there or not correct, let us know. We'll go ahead and get you your answer. All right. All right. And that's for the people that are here. We can't do it for everybody, but for the people that are here. All right. Domain 4, compliance. We've already done query. Now we're going to do 3. We're going to review medical records to identify documentation that is permissible to support code assignment. We're going to ensure the medical record signature requirements are met, and we're going to audit medical records for compliance with coding and documentation guidelines. Let's get into it. All right. So, did you know health records must be authenticated properly, or authorship, or signed by the physician? Yeah. So what is proper authentication? Well, all doctors or qualified healthcare professionals must authenticate their medical records in the following manner. Their signature must have at minimum the first initial, last full name, credential, and date. All right. So this is wonderful, right? R. White, MD, and the date. That's appropriate. The full name, MD, and the date, or the initial, MD, and the date again. Okay. So if a resident is treating a patient, the supervising physician must sign after the resident. Let's make this a little different. All right. So if Jay Johnson is the resident, they're MDs too. But this is appropriate. Jay Johnson, MD, and then their title, resident. And the supervising physician will sign after. Now, any changes or corrections, just thought I would let you know, since we're talking about authentication and signatures, anytime you have to make a change or a doctor needs to make a change, this is how it's done. In a EHR, electronic health record, the original diagnosis, let's say the first diagnosis was heartburn, and let's say the doctor wants to go in and correct it. The second diagnosis is GERD. This is how they do it. Diagnosis correction, they write the diagnosis and they sign it the same way they authenticate it. At least first initial, last name, credential, and date. Always. Okay. Now, if it's handwritten, then this is how it's done. They have to just put a thin line across any corrected information so that you can still see what was changed. So final diagnoses, heartburn, cross it out, GERD, and then the proper authentication. All right, so that's fair enough. You guys got it, right? Right? Okay. And don't forget to date it. Now, here is a progress note. Tell me, is this properly authenticated? Yes or no? It's weird, right? It's like, is this a progress note? Yes, it's a progress note. Indeed, it is properly authenticated. There's the authentication. Minimum of first initial, last name, credentials, and date. And they even have the time. So it is. And a lot of times people look for it at the bottom, but in these EHRs, they're always anywhere, top, bottom. So it is. Good job. Good job. So now that we know about proper authentication, let's talk about items that are codable in a patient chart, right? In a patient record, you can code from the following. You can code from the medical record face sheet. You can code from the history and physical. You can code the consultant's report, the progress note. You saw my progress note, and this is an inpatient progress note. Uh-oh, let's go back. You can code from the medication administration report. You do not code the physician orders ever. Never code physician orders. Those are just instructions. You can code nursing notes, certain things from nursing notes. You can code the body mass index. And remember, this is an ancillary staff member. You can code pressure ulcer stage, coma stage, stroke stage, social determinants of health, laterality, and blood alcohol level. So you can code that. You can code from lab reports, but don't try and interpret the data. If there's a diagnosis on there, you can code it. Radiology reports, if there's a diagnosis on there, you can code it, but do not try to interpret the data. You can code the same from a pathology report, but don't interpret the data. Let's stay in our lane. We can code from operative reports. Of course we can. We can code from anesthesia reports. We can code for ED reports, discharge summaries, etc. So you can code from a good bit of a medical record. That's pretty much it. Now, let me show you how to code an operative report. I'm not going to show you how to do it, but this is how you look at an operative report and abstract from it. All right. First thing I'm going to do, I'm going to ask myself, is it properly authenticated? I'm going to go here, boom, boom. A. Lightson, MD, that's his signature, and the date is here. Oh, he also dictated it, and there's his date. So yes, it is properly authenticated. Does the diagnosis, is there a diagnosis? Yes. Tunica vaginalis hydrocele. Does that diagnosis substantiate the procedure? Well, we had a repair of tunica vaginalis hydrocele bottle type. Yeah, it does pretty much. And if it doesn't, then I would use a resource in real world coding that we're not going to talk about now, but it's the MCD Medicare coding editor. And in part one, we learned about that. And it asked me, is the document dated? And it is. So that's pretty much what I would do for this operative report. And you would do the same for an operative report, for a regular office visit. You would make sure it's properly authenticated. You would look at the diagnosis and make sure it substantiates the procedure. You would look at the procedure to see if the procedure was appropriately described. And it was. And that's it. Yeah, it's kind of straightforward. And I'm telling you, with AI and other assisted um, coding, computer aided coding, CAC, it's quite straightforward. All right, now it's time to test your knowledge. And look at these questions. What is the best source of documentation to determine the size of a removed malignant lesion? A, the pathology report. B, post-acute care unit record. C, operative report. Or D, physical examination. What say you? Well, I thought people would say that. Well, A, they pretty much look at the tissue. They look at the disease of the tissue. And yeah, they do. They do measure it, I'm sure. But that's not the best source. That was key, best source. Is it post-acute care unit record? Absolutely not. They don't even deal with the removed lesion. C, operative report. Indeed. When you're looking at operative report, you'll see the size of lesions. They're always measuring it. And we have to code for the size of the lesion from the medical record, right? Yep. So it's definitely operative report, not the physical examination. And if you said C, outstanding. All right. I don't like this question. Okay, here we go. When coding repair of a lesion, from which report can the coding professional abstract the most accurate measurement? Man, I don't like this. Operative report, pathology report, anesthesia report, nurse's notes. Okay. And this is 54. The other one was 52. The answer is operative report. You all got that. So the answers are, I mean, the coding questions surrounding the codable parts of a record, the questions are similar to that. So they're not really in depth, but hopefully I gave you a idea of what is codable and what isn't. And then we're going to end things with applying ethical coding guidelines and standards, such as the OIG, CMS, AHIMA, LCD, CPT, etc. And we're going to talk about the AHIMA Code of Ethics. One thing that AHIMA insists is the upholding of their code of ethics. So the standards of ethical coding are as follows. Number one, as coders, we have to apply accurate, complete, and consistent coding practices that yields quality data. Number two, we have to gather and report all data required for internal and external reporting in accordance with applicable requirements and dataset definitions. So we can't be lazy. We have to do our due diligence. Number three, we have to assign and report in any format only the codes and data that are clearly and consistently supported by health record documentation in accordance with applicable code set and abstraction conventions and requirements. So we only code the documentation, nothing more, nothing less. Number four, query and/or consult as needed with the provider for clarification and additional documentation prior to final code assignment in accordance with acceptable healthcare industry practices. So we have to follow the query process. And in your LMS, I have provided you with official query guidance from ACTIS and AHIMA. So you don't need it for the exam, but just keep it. When you get to the real world, you are ready. All right, number five, refuse to participate in, support, or change reported data and or narratives, titles, billing data, clinical documentation practices, or any coding related activities intended to skew or misrepresent data and their meaning that do not apply with requirements. Don't do it. Don't do anything illegal. Don't change that documentation whatsoever. Don't participate in it as well. Number 6, facilitate, advocate, and collaborate with healthcare professionals in the pursuit of accurate, complete, and reliable coded data and in situations that support ethical coding practices. So, attending your meetings with your AHIMA regional meetings and um, interacting with colleagues and attending workshops to improve your coding knowledge, definitely do it. Number 7, advance coding knowledge and practices through CEUs, continuing education, including but not limited to meeting continuing education requirements. Definitely. Number 8, maintain the confidentiality of protected health information in accordance with the Code of Ethics. And number 9, refuse to participate in the development of coding and coding related technology that is not designed in accordance with requirements. Okay, so those are the standards of ethical coding. These are AHIMA standards of ethical coding. All right, so we're getting ready to test your knowledge. And I want to know, I got a question, a little scenario for you, and then I'm going to put the standards of ethical coding. And then I want to know, do you code it? Yes or no, and why? You are a coder for a new orthopedic medical group. In the patient record, the documentation for a surgical encounter supports a bilateral procedure, but the physician documented a unilateral procedure. You query the physician who is out of the office until Monday. The physician responds and asks you to just code it as bilateral, and she will make the correction first thing on Monday. Do you code it? Yes or no? Why? Hmm. All right. So it says that it may violate 4 and 5. You query or consult as needed for clarification with acceptable healthcare industry practices and refuse to participate in, support, or change reported data or narrative titles or any coding related activities intended to skew. I don't think these, I don't think 5 is intended to skew or misrepresent, right? So it may not be 5, but it could be 4, but I'm going to say it is 4, and here's why. And this is subjective, but the exam is straightforward. These are just to kind of get you using these. I'm going to say it's 4, and yes, um, you can carry out verbal queries, right? But the doctor said they will fix it first thing Monday. I would wait until they fix it. You know, the doctor can say, hey, go ahead and code it as such and blah, blah, blah. But the doctor has to adjust the documentation. I would not code it until the documentation is completed. And I don't think it's acceptable to do that. So I'm going to say it's 4. And they said, look, you need the signature. Yeah, you do need the signature. So I don't think it's acceptable. Especially, you know, who knows if the doctor doesn't come back? You're in trouble. So these are designed to just get you thinking about the ethics, the ethical coding. All right, here's one to make you think, right? These are not um test like questions. but these are just to make you think. All right. Uh-oh. One second. All right. You are a coder at an obstetrical group. Your wife, who is pregnant, and a patient at the practice had fetal testing, and she's scheduled to see the physician on Tuesday to review the results. She asked you to take a look at her file and let her know if the fetus is normal. Can you provide the information? Yes or no? Why? Or why not? Mm-hmm. We didn't fool you. Yeah, that's a HIPAA violation. And number 8, we have to maintain the confidentiality of protected health information in accordance with the Code of Ethics. So when we study HIPAA, you will see that this is a HIPAA violation. And even though this is your baby, but the patient is the wife. And unless that wife gave you permission to do certain things, and you don't have permission, and if this wife has an appointment with the physician, you don't have physician. Wow, you all, no one, we didn't, no one fooled you. Outstanding. So always be mindful of the standards of ethical coding, the AHIMA standards of ethical coding. And I would just say, there's no way you're going to remember all of them. Some people document them in their book, but I would just say highest ethics, follow HIPAA. You know what I mean? No fraud and abuse. And that's, pretty much it. All right, so we're going to leave. Mm, we have 6 more minutes. And I think I'm going to stop here. And tomorrow, no, Wednesday, you'll have the playback for the full presentation. Okay. And it's not that much more. Okay. So I do want to leave you with your homework, but I did list that the playback will be available on Tuesday. And because we didn't finish, it's not. But just know it'll be available on Wednesday. So here are your assignments for domains 3 and 4. Domain 3, go ahead and download those ICD-10-CM guidelines if you don't have them. Or if you have your MCG, you're good. All right. Watch who establishes outpatient guidelines and rules in medical coding. It will be available Wednesday. Optional, visit the AHA Coding Clinic website. Click there. Optional, view AHA Coding Clinic demonstrations by Liebman Education. That's on YouTube. It's really good, but it's optional. And also, optional, view coverage determinations, your MCDs, LCDs, and MACs. And it will be available on Wednesday as well. It's optional. But sometimes if you need to make that connection, go ahead and watch. And we did review it in part 1. So if it was part 1 if you were in part 1 in October, then you saw it. If you weren't, then you didn't. So it's good to watch. Also, watch AI and medical coding. Click here and basically what we've done tonight if you want to. All right, domain 4, you're going to watch the lecture on compliant queries. You're going to download and read your compliant query guidelines by Actis and AHIMA. It's here. It is heavy, so you don't need to read it. Here you just have to be familiar. All of this, you just need to be familiar. Watch lectures on medical record documentation. It'll be available on Wednesday. Watch HIPAA in medical coding Wednesday. Place of service codes Wednesday. Optional. Read Principles of Healthcare Reimbursement, Chapter 8 in your Principle of Healthcare Reimbursement. It's optional. Also, watch your lecture on Introduction to Medical Insurance. My advice is to click on that, like tomorrow, click on that and watch that if you haven't seen it. This is if the full was carried out in October, October part 1. So if you weren't in part 1 in October, you didn't get the whole thing. So my advice is to watch it and watch Medicare and the ABN, Advanced Beneficiary Notice in Medical Coding. You probably don't need to watch that if you watch this part 1. Okay, so it should be in that part 1 as well. So I just want to thank you all for coming. Thank you, team. I know this was, a long one, a lot of listening, a lot of information that you had to be familiar with, not mastery, just familiar. I need you to complete the survey. You all gave some great feedback in the chat. I will adhere, and I will definitely take another look at that chart. All right. So I want to thank you all. And I want you to have a wonderful, wonderful evening.
Thanks for tuning in. And until next time, happy coding.